Good morning, or not good morning, good evening, everyone. Well, depending on where you are, could be afternoon, but welcome to the third and last session of the virtual forum series, Bringing the Village to the Children, Conversations on a Collective Approach to Children's Mental Health. My name is Desiree DeBella. I am an ACAP Emerging Leader Fellow, as well as a child and adolescent psychiatrist and pediatrician, and I will be guiding today's conversation. This series is part of ACAP's presidential theme, which focuses on strengthening collaborative, multi-sector approaches to supporting the mental health and emotional well-being of children and adolescents. And today's session is especially focused on the intersection of child psychiatry and children with child welfare involvement. We're honored to be joined by Dr. Akeem Marsh, a child and adolescent psychiatrist who has dedicated his career to working with children and families of medically underserved communities, and Cheryl Beamon, a licensed clinical social worker who has more than 25 years of experience working with programs that address the needs of mothers, children, and families. I thank them both for being here and sharing their expertise. As a reminder for all members who are joining us today, if you have any technological or logistical questions, please enter those into the chat and an ACAP staff member will assist you. If you have any questions for our panelists today, please enter those into the Q&A box. And then please note, just due to time constraints, it's unlikely that we'll be able to answer all of the questions today, but we will do our best to get to as many as we can. So just to start off for tonight, for Akeem and Cheryl, could you tell us a bit about your journeys and the role you currently play in supporting children's mental health and what drew you to this work? Akeem, if you'd like to go first.
Good evening. Hi, I'm honored, excited, and delighted to be here, part of this program. So, thank you for the invitation. I am a child, adolescent, and adult psychiatrist by discipline, native New Yorker, and did all my training in and around the city. And my main professional roles are currently serving as the Vice President of the Vincent J. Fontana Center for Child Protection and Medical Director of the Home of Integrated Behavioral Health at the New York Foundling, which is a social service agency that was founded in 1869 by the Sisters of Charity that does a wide range of services, including foster care, mental health support, and other uh, things are more aligned with the mission to strengthen families and help individuals reach their potential. And so, what I do, I would say, as far as how it contributes to broader systems of care, is through direct clinical care, administrative oversight, supervising nurse practitioners, and also signing off on the care of other clients and families who receive support through our program. And then I'm also involved in advocacy through my practice and affiliation with different professional organizations, including the New York City's first ever Juvenile Justice Advisory Board. There's some translational research going on at the Fontana Center that's focused on improving parenting practices. And finally, very much interested, dedicated to supporting the next generation of professionals through partnering with universities, doing supervision and offering rotations and internships.
Cheryl?
That's hard to follow, but I will try. Thank
Aw,
you, Akeem.
thank you.
Um, my name is Cheryl Beamon. I am currently the Associate Commissioner at ACS at the Office of Training and Workforce Development. And I usually like to say I've spent the last 30 plus years working on behalf of children, families, and communities, advocating for them and advocating for the workforce, because I think the workforce is key to being able to provide engagement, transparency, respect, and inclusion. And if we do not advance our workforce with the skills, the ability, and create a culture of trust and respect for them, then I don't think they can model that for children, families, and communities. And so I've dedicated the last 20 years, first on the state level, now on the local level, of developing workforce programs specifically for child welfare, utilizing a variety of strategies and skills. Currently, in my current capacity, I've had the privilege with my team of developing the Institute for Leadership Development because we know workers stay because of good leadership. And so we're proud to say we're on our fourth cohort of leaders who are looking at how do we evolve to meet the needs of the workforce, but also how do we evolve to meet the needs of our community? How do we include them in our conversations? How do we include them in in our planning? And how do we stop, listen, and respect those who we serve? I am also proud to say that my division also awards $1 million of scholarship on over the last 3 years to um, MSW students, both at ACS and our provider agencies. And in my personal life, I'm on the board of director of an after-school program because I believe that we need to enrich and advance our community and those who live in it, and the most vulnerable are our children and our children who are at risk, only because the services that they need to have and the opportunities they need to have are not readily available. So I'm thrilled to be here and to have an opportunity to speak with and with everyone and to share this time with Dr. Marsh.
Well, you are certainly both beacons of collaborative, this network, this work we do together. You both wear so many hats. And yeah, I mean, this next question is, it's probably quite obvious that all of the work that you just mentioned helps build the emotional support and sense of belonging for children and their families. But could you all kind of talk about a story that stands out to you in your work? And Akeem, you can go first again, or Cheryl, either one.
But I was gonna ask if you want to go first, Cheryl, since I took the first one last time.
Sure, no worries. I think for me, I think of a story of a worker spending the time utilizing the skills to create trust with a family. And because if we can be honest, our community has had a challenging experience with our child welfare system. And it requires workers to be able to go out and engage and meet the families at where they at, and also honor and respect that there's a level of distrust, and the only way to override that is by showing up differently, utilizing skills that we train to, like motivational interviewing, unpacking your own implicit bias. And so we had a worker who was came back and reported that she had been working with a family where the mother had some challenges and the children also had challenges. And what she was able to do was to take away the authority that was present in that moment and walk in as an individual and engage that mom in first defining what is a helping relationship. Because so often we assume that parents want our help without first gauging what does help mean for them and where they would like that help to begin. And she talked about how she you know, engaged the mother. She used some family engagement tools, the three houses, the life cycle. And from that, the mother became comfortable in telling her story and identifying what would give her joy and peace and what was her hopes and then what was the fears or barriers or worries that she had. So she was able to use these skills to meet the mother and the family where they at. And then most importantly was that she was able to create trust so that she can engage that mother in her change conversation, not our change conversation, right? And I think that was really important because the mom herself had some mental health challenges, and as a result of that, her children too was experiencing trauma. So I think for me in the workforce, seeing how workers can use those skills to successfully engage and advance the relationship to better service the family to get the outcome of safety, permanency, and well-being.
Oh, yeah, I'm glad you mentioned. Thank you for that. That was a great response, and I'm glad you mentioned about meeting families where they're at because that is also something that I would say I very much strive for. And there's actually there's so many examples that could come to mind. I mean, so many people have been seen and worked with over the years. I'm just gonna quickly recall one that happened very recently, where early this week, I mean not early this, yeah, early this week, last week, I met with somebody who was able to share some of the challenges that took place in the family that they really had been affected by, but was something that was really not much discussed, and even shared that it was hadn't been discussed or even thought about in a really long time because it was so deep and painful that it just kind of suppressed it. And so I was very much uh, sort of honored to be able to provide that space, both physically in the office and the emotional space. And every time something like that happens, it kind of really blows my mind because it's like, this is really a privilege to be able to do that kind of thing. And then even thinking like on a more practical level, of another example kind of related to that is that one of the things that we are fortunate to be able to do is like be able to give out supplies and things that families need. So in the last time it was winter a few months ago, I know it seems so long ago with with what the weather is like now, but when it was really cold out, there was a day when someone came into the office just wearing a sweater and they were like really shivering. So it's like, it was one of those days like you just kind of want to try to avoid being outside. But we were fortunate enough to be able to supply that person with a more appropriate fleece jacket that was more suitable for the weather. And that not only brought a big smile, it also brought a lot of warmth. And so it's like, uh, that's like a very practical thing, right? And mental health is more than just the therapy session. Mental health is also like helping people to meet their basic needs. And so on that note, like I'm very grateful that we're able to do both the clinical care, but also at times help folks meet their practical needs.
Yeah, that's great. We often um, are remiss to believe that we can do the therapy or we can do the outreach or we can do the building relationship if people lack concrete needs are not being met. And I think if I can look back over my career and look at where we evolve, I I I see us being more aware of and more concerned that the mental health is also tied to physical,
Hmm.
Maslow's hierarchy of needs,
Exactly.
those
Yep. Hmm.
basic level of survival, and I have to understand and recognize that if those basic needs are not being met, I can't engage into that behavioral change conversation because they're operating on survival and I'm looking
Hmm.
at some other level of growth. And so that was really a great story because in that moment you did that and you also built the foundation to have that conversation at a different date and time around whatever change needed to happen in their lives.
Hmm.
Yes, that deeply resonates. In my integrated psychiatry clinic, that both of your stories, I feel like I see families who come in and I can't talk to them about sleep hygiene. They don't have a mattress, or, I am, my office is right beside, all of our lovely social workers, and I'm coming to them about like, how are you interacting with this family? How are you like getting their narrative? What do they need from us? So yes, you both are just living and breathing this kind of like collaborative, integrative work. I'm wondering, some of our panelists have talked about meeting individuals, where they are in the community by utilizing leaders within that community as bridges.
Hmm.
And I'm just wondering, how do you ensure that the care and the work that you're doing is culturally responsive and is equitable and is responding to what the community wants? Akeem, can you speak to that?
Yes, yes. So my experience with that actually goes back to when I was in residency and we were doing a research project reviewing the cases of people diagnosed with schizophrenia and schizoaffective disorder. And then, I noticed that a whole lot of them were black, right? So I'm like, that's suspicious. Okay. Fast forward to a few years later, I came across the work of Jonathan Metzl, who authored the Protest Psychosis, which was in a review of the Ionia State Hospital records and basically spoke to the circumstances to which schizophrenia became sort of like a black disease, quote unquote, which, that legacy is still hanging with us. And that was kind of like what sort of put in a foundation as far as like the need for culturally responsive, culturally appropriate, I call culturally relevant and humble care. And so since that time, I'd say I kind of embarked on a path like, doing my own studying and then also like doing presentations as well and doing a lot of writing and like getting a sort of deeper understanding of the cultural significance and realizing that came to the realization that it's like uh, cultural related issues and the things that folks have to deal with are so much related and intertwined with mental health challenges. And because of all of that, besides like making changes in my direct clinical practice, I also do like regularly do like workshops with my colleagues and the other people who work in the agency uh, on racism, implicit bias, and things like that. But it just doesn't stop there because again, going back to what we were talking about earlier with meeting people where they are, making sure we meet them and like make attempts to sort of uh, deepen those connections. We do also have additional trainings featuring folks who have literally are both in practice and are doing trainings on like specific treatment models and cultural adaptations of the different types of therapies that we have to make sure that we're really well-rounded and best suited to really meet folks where they are. And I would say that's a continue. I say this in my presentations, and I'm gonna say it again here. It's like a continuous journey. It's like a continuous process that we kind of have to keep working towards. And it is something that I continue to work towards, and part of the reason why I'm here today.
That's great. So I'll just say on a simple and straightforward level, we work in contract with agencies like New York Family, who
Yes.
help us to reflect the values that we want to instill in our workforce and to drive the work that we want to do in our communities. I think that the community is key because our goal in child welfare is to eventually get out of the lives of families. We're not supposed to be in their lives continuously. Foster care is temporary. And it's, my analogy I like to utilize is that, if you break your leg or sprain your leg, they give you crutches to help stabilize you so you can walk and learn to put pressure back on that leg. And when your leg has healed, those crutches go away because now you can operate on your own. And that's the role of foster care and child welfare is in when there's identified need or concern or behavior that needs to be addressed to promote the well-being, safety, and permanency of the children, we are a bridge or we are a crutch that allows that family to be stabilized. But they have to be stabilized in the community in which they live. And so those community-based organizations are key. Those community advocates and leaders, those community mental health groups, mothers groups, women, children, youth are all resources that we need to build up and sustain and advance and continue to work with. Um, you know, um, Akeem knows that we promote kinship care with our foster families, and we've learned a lot since I came into the field, and that, children thrive in their community. They thrive with the environment in which they know, and families have a right to stay in their community. And so that requires us to build that community resources and then to define for everyone using faith-based organizations, using community organizations, what does mental health services really look like? And then to also partner with NAMI and
Hmm.
other groups to create support groups that look like us and look like the
Hmm.
people we serve. And we also then help to create the language that is simple and elementary, but is reflective of the mental health journey that a parent can be on for themselves or their children or collectively. And then we at ACS has also, and Dr. Marsh knows this, have parent advocates to our foster care cases. Their role as former individuals who have experienced the system is to help guide and provide that parent with the support they may need as they navigate child welfare, as they navigate the mental health system. And I think, lastly, what I would say is that we have to acknowledge that these are all systems. And there
Hmm.
have been systems of oppression in our community.
Ooh.
And you talked about that mixed diagnosis. Those misdiagnoses, the over medication of our children, have been standards that are not false. Um, and we have evolved from that. But those legacy, that history is sustained in our community. And we have to be honest and clear how we are different, how the service we were providing are different, and giving them the power to say no as long as they're clear about the ramifications of that and the implications for them and their children.
Oh, thank you. Can I just piggyback on one thing?
Yes. Oh,
Um,
I just think the exclamation mark. Yes.
I really love the analogy you gave about the crutch. And I want to say that I really think and try to encourage other people to kind of think of themselves as this way, like working in mental health. Like, we're not here to like quote unquote fix anything. It's more like people have a lot of potential, and I encourage people to believe in the potential of other people and really get them like the way I describe it is like helping people heal themselves, right? Like that's what it is we look towards as our goal. And also wanted to piggyback on something else you said about how the the systems have come to what they are today as a result of systems of oppression. That is very much a legacy that we're living with, and now I make sure to include that as part of the discussions whenever possible, and including, both mental health and child welfare, and it's like a lot of overlap between the two. So, thank you for that.
Cheryl, in terms of ACS, you mentioned some facets of this already about collaboration within the mental health sphere and with mental health professionals like Akeem. But how does ACS go about to make sure that children are receiving like coordinated, comprehensive mental health care? Like, what does that look like? What does that process look like? Oh, you are muted.
I think the process begins with a ensuring that each child has the medical and psychological assessment that they need, and then working. So most of our children are in provider agencies like New York Family. And so we have established guidance and um, I want to say protocols to utilize for our children and ensuring that they're getting uh, the assessments they need. I'm sure all our agencies will talk about the frustration of not finding or having enough service providers. I see Akeem shaking his head. And then, you know, sadly, there are a group of children who are have, tremendously challenging behavioral issues because of the trauma that they have experienced over the years and the challenges with Medicaid and all those different things of getting the right service for them based on their diagnosis and their medication. And Dr. Marsh can speak more eloquently with that. But I think what we do is set the expectation clearly that we value all our children. Two, that our children deserve the best mental health care that we can provide. We establish best practice guidance for our agencies, and we review and hold them accountable for that. Um, and we are working with other groups and agencies and CBOs to ensure that those services are readily available. And then, as we talked about, working with groups to ensure that they understand the purpose of mental health services, because we also have the group of the foster parents we have to educate and inform because, you know, um, foster care is multifaceted because we're working to return children back to their parent. We're working with their parent. We're working with the child, the school, the medical team, the psychological team. But we also should be working with that foster parent to ensure that they're providing that gap of they're providing the care needed in this gap, in this moment, and that they're educated and they're informed. So, that's going after and looking at their biases and their relationship with healthcare providers and their relationship with mental health medication and all that stuff that I think Dr. Marsh could speak to more eloquently than I can. But I think those are the things we do. We have standards for our foster care parents. We have best practices and protocols for our agencies. And then we review, monitor on a regular basis. And we are acknowledging that there is a gap there and that, we as uh, uh, ecosystem has to figure out how to resolve that for our children who are really in need of services um, with extreme behavioral issues. So I'll let Dr. Marsh elegantly add on to that.
Yes, that was great. Thank you. It was, it's so children generally exist as part of systems, right? At a minimum, there's usually at least family and school. And fortunately, in the setting that I work in, it's like there are some of those kind of built in a sense. So like one of the programs is school-based where there's multiple satellite clinics embedded in schools across the city. And then there's also like preventive teams which provide in-home family therapy to families in the city. And usually those families, not always, but usually they end up having preventive services as a result of involvement from child welfare ACS. And so that would be at a minimum another system. And so basically my team works and provides the psychiatry services for those families who need them, as well as for other children and families that are seen for like other services, group or individual therapy. And I think that because the children are involved in the different systems, collaboration is crucial, right? Because when we have our appointments, we only see them for a small window of time, right? And most of their life is happening outside of the office. So we need perspective from people who are working in schools, who are working, who are at home with the families, and even sometimes it's helpful to get input from other folks who are involved, like if there's a parent advocate or a child welfare ACS worker involved, because it's like we take in different sources of information and use that to formulate opinions, formulate diagnoses and treatment recommendations. And those are things that we really, can't ignore or shouldn't ignore, can't live without. And those types of partnerships are really crucial to help get children's lives back on track, help stabilize the families, and do what we can to ensure the best possible outcome.
And in thinking about these systems, what challenges, like what recent challenges, systemic policy related challenges have you all encountered in your work? And how have these challenges shaped the way you approach your work? Akeem, I'll have you go
Oh
first.
yeah, I'll start. I would say one thing that I can say it's yeah, I mean, we can call it a challenge like in I believe it was sometime mid-pandemic, like late 2020, early 2021 when the National Emergency in Children's Mental Health was declared. ACAP was part of that, and Children's Hospital Alliance and American Association of Pediatrics. The it was nice, very nice to hear that formally declared, but I would say that leading up to that point, we already had like a quite a crisis kind of a situation that just sort of reached a breaking point during COVID, and now like we're really still feeling and slash dealing with the impact of that, and like long-term effects remain to be known. And so in that aspect, it was like we have, you know, much more needs that exist to be dealt with. And at the same time, we came into that already on a shortage generally of people in the field of mental health and child psychiatrists in particular. And we also have a lack of diversity, a lack of the workforce mirroring the patient population. And I would say how that informs my work is like just kind of, giving that push, like let's do what we can to really try to address these issues, and very much have been working towards that, um, aside from working to support, like having a program, developing it, because, it's not something that even could be taken for granted with all the challenges with, recruitment and retention. Like those are some real issues. And, if we aren't able to recruit and retain, the children won't be able to get services. So, all of those things are kind of factoring in, like and informing the work that's being done and trying to just kind of create a space where this is possible. And, I think it is possible. It's just, an evolving, challenge. So, yeah, with all of that, it's like, we really have the issues of the access to care, and then the being able to meet the demands of the patients that we work with. So, we really try to be creative and engage in whatever ways we can.
Oh, you're muted, Cheryl.
Myself, I know. I would just agree that the shortage of professionals to service our families is probably key. I know the mayor has been addressing that for the last year. And I think that you spoke about the systems, and I think that those things um, the 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 shortage of people to be able to meet those needs or to meet the needs of our communities then gets played out in all the systems from
Hmm.
overwhelming the emergency rooms, right? To the school system labeling children problematic or calling in to child welfare because their parent is not caring for them and sending them to school either, you know, n calling attention to them, right? To um, you know, older children being on the street, being vulnerable to gangs, being vulnerable to sex trafficking. And so, all these systems have to um, acknowledge that our communities was, as Dr. Marsh said, hemorrhaging before COVID. And then COVID, the hemorrhaging became more apparent. And so then we have an intersection of the immigration, of the people coming into New York City because we are, I shouldn't say we're, but we are a sanctuary city. And then I think now we have to deal with the fear that, should I go and get help? Because is that something that will make me vulnerable to being a victim in a larger system of oppression, right? And so we have to, as that system of identifying who should not be here keeps expanding, both in who they are and where we touch them, then I think we're also creating this fear that I'm not going to get services, I'm not going to reach out. And so um, I think the key part about all of this is all of the systems of health, the hospitals, the schools, the faith-based organizations, the city agencies, child welfare, all has to remember that the vulnerability and fear are intertwined, and that as a result of that, what does what is the conversation that we need to have in the community with the community leaders? And then how do we stay in the community? Like how, like we tend to just go to the community when there's a defined emergency, but then we leave or our services become less or funding is reduced, but doesn't mean that the community is healed. It just means that it was a stopgap moment, right? And I think we have to, as a collective, to believe that healing is a long-term solution. I know, I don't know if that all made sense because it was in my head, but I do feel that the systems have to agree that is a long-term solution, that we have to build the infrastructure to support our communities in a variety of pockets where people, children, and families interact with that system.
No, that was on point. Thank you.
It all made sense, complete
Hmm.
sense. The Q&A is just buzzing. I want to get to one more question before we switch over. So for both of you, what insights or recommendations would you share with others that are working to improve children's mental health and well-being, specifically within this sector of children's welfare systems, either individuals who may be in training, out of training, not going necessarily into a clinical pathway afterwards, but they want to work more in like organizations like ACS, what recommendations would you give them? And Cheryl, I'm going to go to you first.
I would say first, we in child welfare in New York City ACS are constantly evolving. We are always examining who we are, and who we were to become who we need to be in our communities. And I think one of the things that I would say to folks who want to come in is come in with humility, humility on multiple levels. One is a cultural humility, and I would say that's organizational child welfare humility. It's a very complex, demanding field of work, but there are thousands of people every day who do this work with their heart, their mind, and their actions, that they are intentionally not looking to for any reward other than to be able to know that they did their best for that child and that family in that moment in a complex bureaucracy, but they are committed to this work and they make sacrifices. I think child welfare is one of those fields or areas of work rather where there is a overwhelming Monday morning quarterbacking that goes on, right? Because you know, we are we are not gods, and so we can't control human behavior. And someone who you work with on Saturday could be on Friday, could be well, and then they have a triggering event on Sunday that you didn't even know about or was aware of. And there's a remorse, a fear, a sadness that comes with that. And so this is heavy work. And I used to say to the group who I trained as new case workers and social workers is that this is not for everyone. So make the decision if you're going to show up, that you're going to commit to be your best. And then when you can't, unpack that and inform the people so that you don't do any harm, right? And so I would say for those who are coming, come with humility, come with commitment, come with courage, and come with a sense of purpose around the work. Regardless of where you are in this system, if you have those things, you can have impact. Not everyone is supposed to do direct services, but we all can move the system better towards serving children and families.
Solid. I really like what you had to say. So, and a lot of it overlaps with things I would usually say. So I'm really just gonna piggyback. Only thing I want to add is one, be ready to learn, right? And also be flexible. And the fields are very much evolving. So if you have a desire to be involved, um, like Cheryl said, direct service is not for everyone, which I fully agree with because that's something you kind of have to be like prepared for. Like, I'm ready to take it on. And if you're not, that's okay. Like, there's many other ways that you can be involved, can be down for the cause. I would also like to add that a couple other things. There are a lot of uh, information and a lot of things that happen that can be experienced as negative because this is reality, this is life, and so many people have so many things that they go through, but that's not the whole story. And in fact, there are many times positive things. So I would say appreciate when those magical moments do come up, and let that be what helps to guide you going forward. Like, on an example of what I mean by that is back to the short story I gave earlier about just being able to provide space for somebody who um, hadn't really had that opportunity in a long time or even ever. Like, many times we'll see people who are just opening up for the first time on, this really sort of challenging topic. And the last thing I wanted to share and mention is that in the areas and in the spaces where decisions are being made, we usually don't have children represented and not represented in a way that they could and should be. So we really need people to really and genuinely care about the children, take into account their lived experiences, and, like, let's, whenever possible, hear directly from them and listen to them. Like, got to listen to the children and then advocate for them as if our future depends on it because it really does. Like, what's the world going to be with, without the children, keeping it going. So, uh, yeah, so I'll just like to touch off on that before we hop into the Q&A.
Thank you both. So there are quite a few questions in the Q&A. We will not get to all of them, but we're going to go ahead and get started. So there was a lovely question about, could you speak more to having child psychiatrists develop relationships with the foster care system that is supportive and instructive, being able to recognize that each should be working in tandem to assist the child and family in optimal development?
Mm. It's funny because for me that's easy. Like I'm actually in the same agency that I'm working in is like also does foster care agency. So we're like hand in hand, like we're eye to eye. It's it's not as much of a challenge as it would be working with a separate community-based organization. But what I would say is for people who are working in community-based organizations, I mean, I think if that agency is going to work with foster care, youth who happen to be in care, they really have to be committed to making that effort and making it work because the general needs for young people in foster care are much higher than they are for children and families who are not. And it's just like there happens to be, there's often lots of layers involved. Because before I mentioned, like, all children are in some type of system or another, whether it's at least their family unit and or school. Children in foster care will have their birth family unit, well, now we say resource family unit. So they have a resource family unit. They'll have like case planners. They'll have um, maybe an ACS worker, maybe an attorney who happens to be their advocate. And so like there's lots of people involved. And so like saying like you're going to work with children in the foster care system is really like an extra commitment and it's extra necessary commitment because there's so many children who have mental health needs. So I think organizations and child psychiatrists uh, should get on board to advocating for like, making sure we as an agency do what we can to help support these children because they really have high needs and they need that. Like they all deserve, top tier, excellent level of care.
Yeah, I agree with Dr. Marsha. And I would also say, one, understand that it is a system that is governed by state rules and regulation. So if you have opportunity to learn more about the Office of Children and Family Services, um, which supervises and provide oversight to the New York City child welfare system, that would be good. I would also say that if you currently do not have foster children on your case or your in your on your on your load workload, I would suggest that maybe you volunteer at a foster care agency. I think to understand who your children and youth, and I want to say youth because we always say children, and yet our youth are the group that is underserved and
Hmm.
often have years and years of trauma, and they're the group that is hard for us to get their needs met. And
Hmm.
so I would say, get an opportunity to mingle and learn and volunteer at an agency to learn about who you should be serving, and then looking and learning about that complexity of what we call the triangle, the birth family, the foster care, and the agency. and how
Hmm.
you have to be in communication with all of them. And there are probably other folks, but with all of them around, what are the needs of this child? What is the plan? An agreement that everyone is agreeing that this is the plan and how you can best service them. And then commit that this is hard work and that you're going to do it. And if you can't do it, then to gracefully exit before you know, if you can't find that this is not meant for you. So,
There was also a question about how how can you incorporate psychoeducation, like proactive psychoeducation, into the requirements for becoming foster care parents, and ensure that children are matched with parents that are equipped to handle their pathologies? Is that something that's happening, or is that?
yeah. So recently at ACS, we um, moved to a framework called Enhanced Family Foster Care, where we train our foster parents on trauma. And what does trauma look like? So a trauma informed response parenting course. We also adopted New York State adopted the national foster care training curriculum, the national in DC curriculum. Um, and so part of that curriculum is informing them on trauma. And I think there is ongoing training and education that happens at the agencies when a child is placed on medication or medicine regimen rather. And I think that's ongoing. And I think, again, part of the work that we do and the agencies as well is that we interview, we vet, and we train our foster parents. And so we at the agencies they do case home studies, they interview relatives and references. And then the training is a pre-selection training where we hope that in that first training, if this is not right for you, and in conversation with your agency, you can choose to not move forward. So we don't want everyone who says they want to be a foster parent to be a foster parent.
Hmm.
We want those who understand that you're you're getting a child that needs healing and they need a person who can be informed and educated and understand the complexity of that, and then to work with their parents if that is appropriate, because what you'll find is that children want their parents,
Hmm.
want to be with their parents, they love their parents, and that judgment that sometimes comes from us as adults, we have to learn to manage that and think about the safety and well-being of that child, of course, but we also have to think about their heart. Where is their heart and how do we help heal it? And that may be by being in relationship with that parent.
Well stated. Yeah, I'm not actually directly involved in like the process of becoming a foster parent, resource parent, or selection, but I do help support the training efforts and so some of the programming and that's done, like I help, make sure that important information is relayed. And of course, like anytime, working with families, like psychoeducation is always part of it. Even if because I'm sure like everyone has to have had some level of training, just kind of reinforcing the same kind of concepts that have been shared, like explaining how maybe this, um, what we're seeing is like a trauma reaction and it's not necessarily something that could be medicated away. And, this particular behavior is done as a result of survival coping, meaning that it happened developed as a result of a means of literal survival, and it's just happening now again because, those things don't just evaporate, it takes work to sort of process and really understand from the youth perspective. And so yeah, but it is yeah, it's important, and we gotta really um make sure everyone is sort of knowledgeable and knows what they need to help meet the children's needs.
I'm going to go to one last question. There are so many amazing questions in the Q&A, but this particular question I don't think that we've touched on yet in this series of this idea of systems and becoming frustrated with systems and just saying, I'll do it, and how that can lead to burnout. How have you all managed to find a balance in your personal and professional life while maintaining comfort and or satisfaction with the work that you've done?
Secondary trauma is real.
Hmm.
Um, it is a true indication. It's a true real is a true element of the work that we do. And so I think one of the things that I do is who's in my circle that I trust enough to be able to pull my coattail. I joke with friends. It's like I can't find my keys. I can't find my keys to close the house door, and the keys are in my hand. There's something about being vulnerable enough to be able to admit that you're in pain from the work that we do. I think that that is the first step, is that admitting that this work is hard and creating a circle of people who can tell you, you have your shirt on the wrong way, or tell you
Hmm.
something, and you being honest enough. And for me, for you it could be vacations, it could be yoga. For me, it's my faith, that helps me ground me in knowing that I'm not God. I am a representative of his light, and all I can do is shine brightly in those areas where there's darkness. And and if I do my best, that includes rest and my own mental health. And I think, that's a bigger issue for us who work in human services, is that how many of us have our own mental health issues and that we need to address. And so for me, that's having good therapy and good friends and sometimes a good glass of Chardonnay in moderation.
Oh, yeah, secondary trauma is real. That was a excellent acknowledgement. And it just, what you ended off with was like made me think of one of the phrases that we hear often, and that is you can't pour from an empty cup, right? Like you need to have a fill. You got to take care of yourself first. And or the other analogy is the instructions that they give on the airplane, where it's like put your mask on first before you help someone else. And I think those are really real. I'm just trying to think, like there was a certain point where it really kind of hit me, where I really realized like there's there's limits to what you can do, right? Because it's like you can't, it's not possible to be everything for everyone at once. Like it's literally not possible. And so once that really kind of sank in, like really sank in, then it's like, okay, I'm gonna show up and just do the best that I can each day. And sometimes the best that I can is like, barely making it to a meeting, like in the meeting, like, I'm here. Or sometimes I can't even make it. We have sick days, we have those kind of things. So you should take advantage of that. So sometimes that's the best I can do. And it's like it's okay, whatever I can't get done today can try again tomorrow. And that's the best we can do. And just kind of live by that, above and beyond a lot of what Cheryl already talked about.
Yes, yes. So thank you again for to both of you for such a meaningful and engaging conversation. There were so many points in this forum today that I had goosebumps. So many amazing just like words were shared today. I think your insights have really deepened my understanding. Hopefully, everyone who's in attendance, their understanding of how to build and sustain collaborative systems that, are truly supporting children's mental health, youth's mental health and well-being, families' well-being. Um, I want to be cognizant of time, and we are at 9 o'clock. But to individuals who put in the Q&A, I will try to forward your questions to Cheryl, to Akeem to get you some answers because there were some excellent questions there that we didn't get to. But yes, thank you both for all of the time and the important work that you do. And thank you for everyone who joined us today. Yeah, I hope everyone learned something today and is going to carry it forward in their work for tomorrow.
Thank you. It's been a great opportunity. I celebrate your work and the work we're doing together, and I celebrate everyone on this call because we all matter, and child welfare matters, and our children matter. So thank you. Thank you, AACP.
Thank you. Yeah, echo the sentiment. It was an honor. It was a privilege to be able to do this work and share insights. So thank you.
All right. Well, over here in Cincinnati, it's nighttime. So I'm going to tell everybody good night and
Good
be
night.
safe.
Bye.
Bye
Bye
bye.
bye.